Hello, good evening, friends. I'm back with Polyhydramnios part 2. Yesterday, what happened last 5 minutes, there was some glitch and my audio was not clear. So that's why I had to stop the class abruptly. And today I will continue with the management of the Polyhydramnios. I don't think I need to recap about the Polyhydramnios, the etiology and other things. Let me straight away go to the prognosis part of it, the fetal and newborn prognosis. As you know, polyhydramnios can cause preterm pre-labor rupture of membranes. It can lead to preterm labor itself and preterm birth. That itself will have a lot of complications and problems for the neonate, and the prognosis depends upon how preterm was the baby. Preterm birth in affected pregnancies also may be caused by iatrogenic interventions. Polyhydramnios per se causing preterm labor is one thing. The iatrogenic interventions in the form of amnioreduction or any other method can itself give rise to preterm labor, abruption, or maybe even sometimes cord prolapse if you are not very careful. These things can happen. The overall risk of fetal death and neonatal death appears to be increased in polyhydramnios. That's why we cannot neglect polyhydramnios, nor can we neglect oligohydramnios. So these come under high-risk pregnancy, and we have to monitor them very closely. The risk of death depends, of course, but relative risk increases with increasing severity of polyhydramnios. The more severe the polyhydramnios, the risk is also more, which obviously may be because of the fetal problem to start with, or the other problems that can be caused by polyhydramnios. The absolute risk depends upon the etiology. For example, the combination of FGR and polyhydramnios has a particularly poor prognosis, including perinatal death. That is because of high prevalence of fetal chromosomal and structural abnormalities in these babies. So polyhydramnios per se can cause death due to its complications. And then if polyhydramnios if it was due to a fetal structural or chromosomal abnormality, it will add to the death rate or poor prognosis. I hope it's clear. Now, what about idiopathic polyhydramnios? It is associated with an increased risk of neonatal morbidity at term. We don't know the cause, but as I told you yesterday, out of 40% idiopathic, after birth in good number of them, 25% of them, we can find out some anomalies, okay? So especially neonatal respiratory morbidity, RDS, is very common in idiopathic polyhydramnios. These and other adverse sequelae are likely related to underlying etiologies such as malformations, genetic syndromes, and neurological disorders that were not identified before birth. Again, I'm repeating, though we say 40% of the polyhydramnios are idiopathic, after birth, 25% of 40%, okay, we can find out some causes which were not detected during antenatal period. So that may be the cause of neonatal respiratory morbidity, is the meaning of this particular slide. Now I come to the main part of the today's talk, that is the management of polyhydramnios. As you have understood, diagnosing polyhydramnios is one thing, finding out the cause of polyhydramnios is another, and obviously the management includes both, that is managing the polyhydramnios, one thing, and managing the baby, which is the cause of polyhydramnios. So it's a total package. And then, of course, if mother is the cause of polyhydramnios, that is, let's say, diabetes, then managing that part is also a part of management of polyhydramnios. So it's a total thing. Let us look into it. In singleton pregnancies, that means polyhydramnios is not due to twins, not due to TTTS. It's not a oligopolysequence. It's a singleton pregnancy with an identifiable etiology. That means we know the cause. Maybe it's a GDM or a type 2 diabetes, or we know that there is a fetal anomaly, or whatever it is, we know the cause of polyhydramnios. How do we manage that? The specific underlying etiology should guide antepartum fetal and maternal surveillance, including intrapartum management and timing of birth. Meaning, suppose the cause of polyhydramnios is diabetes, then the management is exactly as you would manage a case of diabetes. You are not, singling out the polyhydramnios part of it. It's a total package. You are managing the GDM or the diabetes of the mother. Automatically, polyhydramnios is managed. So that is the meaning of this. So which includes maternal surveillance, her sugars, fetal surveillance, and then of course, how you manage the intrapartum and how you time the delivery, where you conduct the delivery. All these things are guided by GDM rather than polyhydramnios alone, because we know the cause here. Similarly, if the cause of polyhydramnios is, let's say, a particular chromosomal anomaly or a structural anomaly, the entire focus is on that structural anomaly rather than on the polyhydramnios. Polyhydramnios becomes the side part of it, right? So you are basically considering how to manage this baby. Suppose the baby has a congenital diaphragmatic hernia. So entire management depends upon when to deliver her and where to deliver. Obviously, it's a tertiary care center where pediatric surgeons are available. It's like that. So all these things a PG has to write in the exam. Here in the PPT, you will just find 2-3 lines. But these 2-3 lines have to be explained properly in the answer. That's where the difference between one PG and another PG, one obstetrician and another obstetrician, and one person to another person comes in. For patients with severe symptomatic polyhydramnios, the management of maternal symptoms is similar to that of patients with idiopathic. What is the meaning of this sentence? The meaning of this sentence or this point is that just the polyhydramnios part of it, which is causing maternal distress in terms of maternal respiratory problems and other things, discomfort and other things, then the management is same, whether the cause is identifiable or an idiopathic cause. Okay, so that part of it, just the polyhydramnios part of it, that's the meaning of this. Okay, now I come to that. What is that meaning? What is the management of idiopathic polyhydramnios, where we do not know the cause, what is causing the polyhydramnios? So we have to manage polyhydramnios as well as the pregnancy, as well as the mother and the fetus altogether. How do we do that? Obviously, it depends upon. My favorite starting answer always is depends upon. I always teach the PGs, undergraduates, saying that when you don't know the answer, just book the answer by saying depends upon. Actually, you may not know what to talk after that, but the examiner will get impressed sometimes. So depends upon means the student must be knowing all the possible answers. So he will say, okay, fine. So just when you don't know the answer, say depends. Okay, depends upon. Of course, you should be able to tell what it depends upon. Here, it depends upon gestational age. For example, if the gestational age is very low, you are not ready to deliver. That's why you may have to manage the pregnancy. Maybe to relieve the maternal symptoms, you may go for amnioreduction and continue with the pregnancy. It also depends upon severity. Sometimes, in spite of repeated amnioreductions, if it is so severe and it is unsalvageable, then you may want to terminate even if the gestation is not term. And presence of symptoms. Again, as I said earlier, if the symptoms are very mild, then there is no need to manage at all. But if the symptoms are there and if they are severe, then you have to manage. So the management of idiopathic polyhydramnios depends upon the gestational age, severity, and presence of symptoms. All patients, whether they have symptoms or no symptoms, or irrespective of gestational age, whether they are primary, multi, whatever it is, antepartum fetal monitoring is the bottom line. That, in fact, finally, if you realize in obstetrics, it is fetal-maternal management, fetal management. That's all. It's such a simple, straightforward subject in a way. So, and if you come to fetal monitoring, it is same for all. That's why I have no hesitation in telling obstetrics is the easiest subject on earth, because it is very well defined, very clear. There are set of things to be done. It is almost same irrespective of the complication. Just the management of the particular problem will vary. For example, if it is hypertensive disorder, management of hypertension. If it is a hyperglycemia, management of hyperglycemia. Other than that, fetal monitoring, fetal management, maternal monitoring, maternal management, by and large, is almost the same. So that is to be done in every single patient. For mild to moderate cases of polyhydramnios, biophysical profile, BPP means biophysical profile, upon diagnosis and then every 1 to 2 weeks. Towards the term, maybe every week. So earlier it could be once in 2 weeks maybe, but usually we do it once in a week nowadays until 37 weeks. In a hospital setup, when the patient is specially admitted, we usually do every week. But maybe in other setups where there is no ultrasound in the nursing home or in the hospital, if you have to send it for to some other center for ultrasound, maybe you will do once in 2 weeks. Otherwise, in a place like Manipal, we do BPP sometimes twice a week. Every week to definite, and then weekly from 37 weeks. Once she crosses 37 weeks, which is considered term, then you have to do every week. There is no excuse. As I said, maybe sometimes twice a week. For severe patients, BPP every week, right from the diagnosis until birth, maybe towards term twice a week. I hope it's very straightforward. Symptomatic, but asymptomatic, and non-severe polyhydramnios, what to do? Intervention to reduce amniotic fluid is not indicated. In fact, don't do anything. Don't give medical management. Don't give this surgical management of amnioreduction, because it is asymptomatic and it is non-severe. Yes, polyhydramnios you have diagnosed. You can diagnose what's the cause of it and all that. The management is mainly targeted towards that. For example, again, if it is diabetes, then you treat the diabetes. Don't worry about polyhydramnios because she's asymptomatic. Our patients with mild shortness of breath, abdominal discomfort, and/or uterine irritability, that is reasonably tolerable. So don't start even tocolytics. Don't start anything if it is just an irritable uterus, as pregnancy outcome may not be adversely affected. So unnecessary intervention should be avoided. That itself can give rise to problems. Suppose you start a tocolytic just because uterus is irritable, that tocolytic itself can cause cardiac problems to the mother. Most of the tocolytics have that kind of a problem, isn't it? And if you try to do amniocentesis just like that, that itself will ask for infection, it will ask for preterm labor, it will ask for PROM, whole lot of problems. So best is no touch technique. And there are no interventions that improve pregnancy outcome. Even if you do some interventions like this, the pregnancy outcome may not be better. In fact, it can be worse. As I said, it can give rise to iatrogenic preterm labor. Whereas if it is severe polyhydramnios, please follow this flow chart. It is a beautiful one. So the questions that are asked in the flow chart, first is, does the patient meet criteria for amnioreduction? Is it so severe? Is it very symptomatic? It is distressful for the mother. Then that means shortness of breath, severe abdominal discomfort with or without uterine irritability. Then there are two options. One is, answer is yes. Obviously, you have to perform amnioreduction, decompression of the fluid, and administer a course of betamethasone, because, as I said, amnioreduction itself can trigger a preterm labor. Even otherwise, you would have been getting into preterm labor. So you have to be prepared, betamethasone per standard guidelines, and treat uterine irritability if present, maybe with a tocolytic. So if adequate resolution of symptoms occurs, manage expectantly thereafter. So it's very clear. But if the answer is no to this question, that is, patient does not meet any criteria for amnioreduction, then you ask a question again, does the patient have already preterm labor without your intervention? Because as the uterus stretches, there can be contractions and she may get into preterm labor on her own, or she may have got a high leak and that will give rise to preterm labor. So that's the question that comes up. Now, for that question, that is, does she have preterm labor? If the answer is yes, then you have to manage the preterm labor. Of course, it goes without saying, if the patient is less than 32 weeks, you have to give her both neuroprophylaxis in terms of magnesium sulfate. Also, you have to give tocolytics for treating the preterm labor, and you have to give steroids for lung maturity. So all the three have to be done. This has become almost like standard. Even if you are in the deep sleep, you should be able to answer these three things as far as preterm labor is concerned. And I'm sure even the first year PGs have understood this very clearly, and they will answer spontaneously. But if the answer is no, then of course it is expectant management, as in case of where you have done an amnioreduction and the problems have been resolved. Now, on the other side, after amnioreduction, if the symptoms have not been relieved, that is refractory severe symptoms, you have done a good amnioreduction, but still the symptoms are persisting, then you ask the question whether the patient is less than 34 weeks or more than 34 weeks. Obviously, because after 34 weeks, we consider it as a mature baby, in the sense lungs are mature and there is no need of any neuroprophylaxis, though it is a preterm baby. Repeat amnioreduction, because it's better to always go beyond 34 weeks. For gestation less than 32 weeks, only consider 48 hours course of indomethacin. I'm going to talk more about indomethacin shortly in the subsequent slides, for its tocolytic and amniotic fluid reducing effect. So first of all, indomethacin will act like a tocolytic, number one. A second one is, it will also reduce a little bit of amniotic fluid. I'm going to explain that how. But if the patient is beyond 34 weeks and if the symptoms are refractory, not relieved by amnioreduction, repeated amnioreduction, discuss the option of preterm delivery for relief of symptoms. Ultimately, one dictum in pregnancy is that if any problem has occurred because of pregnancy, the ultimate answer is delivery. Take, for example, preeclampsia. Severe preeclampsia, the answer is delivery. Severe fulminant hepatitis due to pregnancy, answer is delivery. If it is a severe polyhydramnios not relieved in spite of repeated amnioreductions, answer is delivery. The question is, am I prepared to deliver her? Is she 34 weeks or not? That is the question. Have I given her steroid prophylaxis? Have I given her neuroprophylaxis? Am I ready with the NICU? So these are the questions. These are all very, very, very straightforward. Even a first or second year PG can sit down, just like close your eyes and draw a flow chart on your own, because these are common. This kind of questions you will see in every single case. Okay. Now, amnioreduction. Let me talk a little bit on this, because there can be a short note on amnioreduction itself. There are many reasons why we do amnioreduction, but the major reason is polyhydramnios. There is no consensus about how much amniotic fluid to be removed in a sitting. I hope all of you have experienced that. Number two, how rapidly it should be removed. There are several methods of removing. Some people just remove with the syringe and they keep on doing that. Some people will connect it with a drip connection, and it will go into the bottle. There are very many methods of removing the fluid, and how rapid it should. Then, of course, another question is whether to use tocolytics at all or not. And then, since we are doing an invasive procedure, should we give antibiotics? It has become almost common practice in India, at least, that whenever we do some procedure, we don't want to take any risk, because in spite of observing all aseptic precautions, sometimes we are not very sure about that. So giving antibiotics has become a routine. At least one dose of broad spectrum antibiotics we usually give. But in the West, they have understood now it is always better to avoid antibiotics as much as possible, unless there is a definite indication or there's evidence of infection. So this again becomes a controversial, no consensus. A reasonable guidance is to remove not more than 2 to 2.5 liters at one time. All of us know that a rough estimate of amniotic fluid is around 1 liter at around term and slightly more before that. So if you think that it is much more, then you know that it could be 2 to 2.5 liters. But again, measuring that, we can easily measure because we are removing it. But finally, you should leave behind some liquor also. So maybe if you achieve AFI of less than 24, which is the point of diagnosis, or if you find that single deepest pocket SDP is less than 8 centimeters, there you can stop probably. So both quantity wise as well as AFI wise, SDP wise, you can take a guidance together. So because there is no clear cut guidance anywhere. No faster than 1000 ml over 20 minutes. So in other words, it has to be very slowly decompressed. If you suddenly decompress, there can be a chance of abruption. So that's why you have to do it very slowly. In fact, you can go slower than this. Although rates of 100 to 125 ml per minute have been reported, that is little dangerous. You don't have to do anything. Maybe you have to sit next to the patient for 20 minutes or 30 minutes. If you don't have time, don't attempt at all. If you have time only, you do this. And it is always better to go slowly. Initiate indomethacin in patients with contraindications. Okay, so the contractions. Indomethacin is preferred to other tocolytics because other tocolytics have got cardiac problems, issues. As it is, the patient may be having some stress on the cardiac. So that's why indomethacin is better. It has an added advantage, as I told you, to reduce the amount of liquor. Also, I'm going to come to that very shortly. What are the complications of amnioreduction? Most common being PPROM. See, what you want to avoid itself can happen. We want to avoid preterm labor, that's why we want to go for amnioreduction. But amnioreduction itself can trigger PPROM, maybe due to infection or maybe sudden decompression, the amnion can shrink, and that shrinking, the shearing type of force can occur and PPROM occur. And PPROM, we know, will usually lead to preterm labor, and preterm labor will give rise to preterm birth. This is the biggest complication of this procedure. The less common complications are, thankfully, abruption is like one of the complications, but it is less common. And intra-amniotic infections, if you observe strict aseptic precautions, this should not occur ideally. And then hypoproteinemia, because you're not going to really remove so much of fluid in a given setting, so hypoproteinemia may not occur. Follow-up, how do you do that? Monitor amniotic fluid volume every 1 to 3 weeks, maybe less than that, 1 to 2 weeks. And as indicated by the progression and severity of amniotic fluid reaccumulation process. See, this is another thing which I always tell my PGs and UGs, that the fluid around the baby is not a stagnant water. It's a dynamic water. Every day it is being secreted in a way, and it is being absorbed. So that's why reaccumulation occurs sometimes with vengeance, something like vengeance tourism we have been doing after Corona. So if you remove some fluid comes back with vengeance. The same thing happens, we have seen in ascites of ovarian cancer. If you do if you remove some fluid in the ascites, it comes up very fast. So that is what is the experience has been. So repeat procedures can be performed at any interval on an average to at least 1 week apart. So we don't do everyday basis or alternate day basis. Usually we give 1 week time to repeat the procedure, are needed to reduce amniotic fluid chronically present. Now I talk a little bit about indomethacin. This also can be a short note, especially for postgraduates and undergraduates. The Society for Maternal and Fetal Medicine recommends not administering indomethacin for the sole indication of reducing amniotic fluid. Though it can reduce amniotic fluid, but indomethacin should not be used to reduce the amniotic fluid. That is the meaning of this sentence. But you can use it if the patient has gone into contractions, because this is relatively better tocolytic compared to other beta adrenergic sort of tocolytics, beta agonistic type of tocolytics. However, in pregnancies less than 32 weeks of gestation with preterm labor, uterine irritability, a short course, they are specifying short course means 48 hours of indomethacin for its combined effects of tocolysis and reduction of amniotic fluid may be used. So for the sole purpose of reducing amniotic fluid, it should not be used. But if you are using it basically for tocolysis of a short tocolysis of 48 hours, then you can reap the added advantage of the reduction in the AFV. Okay, that's the meaning of it. What are the adverse effects? It's nothing is safe. No drug is safe. Even indomethacin has got some adverse effects. The concerns when the drug is used for more than 3 days. That's why the Society for Fetal Maternal Medicine recommends it less than 48 hours. If you use it for more than 3 days, and when it is used after 32 weeks, okay, not before 32 weeks. That's why in the previous slide you saw that less than 32 weeks, a short course. So if it is used more than 3 days after 32 weeks, it can give rise to premature closure of ductus arteriosus in the baby, renal impairment in the baby. It may stimulate fetal. How does it reduce the fluid? See, here is the mechanism. It may stimulate fetal secretion of arginine, vasopressin, and facilitate vasopressin-induced renal antidiuretic responses, and reduce the renal blood flow, thereby reducing the fetal urine. But if it goes to an extent, if you give it for a longer time, so for a shorter time, this looks a beautiful mechanism by which it will reduce the amniotic fluid. But if you give on a long-term basis, it will cause the renal impairment of the fetus. They also may impair production and enhance reabsorption of lung liquid. That can be dangerous in a fetus. So, okay, so these has to be kept in mind whenever you use indomethacin. What is the dosing? 25 milligrams orally 4 times daily, and limiting treatment to pregnancies less than 32 weeks, again stressing the same point, and a shorter course of 48 hours with respect to polyhydramnios. Okay. Sometimes we use 75 milligrams per day also, that is 3 times a day. Maternal side effects are also there. That is nausea, vomiting, esophageal reflux, gastritis, but all within 4%. Platelet dysfunction. Again, it will not be so severe if you use it for a short period. Alterations in maternal cardiovascular physiology are also there, but it is minimal compared to like other tocolytics that we use. Now I come to place of delivery. No prize for guessing. Polyhydramnios cases should be delivered in a tertiary care center for patients with severe idiopathic polyhydramnios, since clinically important fetal abnormalities may not have been identified prenatally. So, as I said, I will repeat again for the last time, please excuse, 25% of the patients who have been diagnosed as idiopathic polyhydramnios can have actually fetal abnormalities, which can be diagnosed in a tertiary care center. That's why these people should be delivered there. And suppose there is a cord accident, so there's a cord prolapse, immediate cesarean can be done. If it has to be delivered in a preterm situation, NICU facilities are available. For all these reasons, and maternal complications, fetal surgeries, or rather pediatric surgery if it is required, infant surgery is required, all these are available in tertiary care center. All these points have to be told beautifully by the PGs. See, one secret in exam is that you keep talking, like how I talk. So you talk in such a way that you have got 20 minutes time in the exam, keep talking, and I usually say hijack the brain of the examiners. So examiner will not feel like asking any questions because you are talking continuously. You know all these things. Use of uterotonics for induction. What is the concern? Although there is no absolute contraindication to use oxytocin or prostaglandins, these drugs should be used with caution. Why? There's a marked increase in the incidence of PPH related to atony of patients with polyhydramnios. You may wonder if atony is the cause of PPH, we know that due to polyhydramnios, why can't we use uterotonics? But sometimes what happens, there's a rebound relaxation after contraction. So that's what happens. So The use of uterine stimulants may increase the risk of both PPH and amniotic fluid embolism. PPH is dangerous anyway, but you have some time to save the mother. But if amniotic fluid embolism happens, you have no time to save the mother. So you have to be very cautious while using uterotonics in a polyhydramnios case. It sounds little paradoxical to you. When the uterus is relaxed, why don't we use uterotonics? The Sterling law says when you stretch maximum, you contract maximum. But if you stretch beyond a point, then no amount of contractions or no amount of uterotonics will help. But if you use uterotonics in a heavy fashion, it can cause amniotic fluid embolism, or it can cause rebound relaxation sometimes. So what's the timing of delivery? It is influenced by underlying etiology and severity, like anything. Mild to moderate and normal BPPs, you can induce, you can go up to term 39 plus weeks or 40 plus 0 weeks also, as the risk of fetal death appears to increase significantly at term. So beyond that, you don't go. So beyond that is post-term, you don't go. The chance of fetal death increases. But 39 weeks is now the new term, actually. Earlier, we used to say anything beyond 37 weeks is okay. Now, 37 to 39 is considered like almost like a late preterm, because the chance of RDS is still there. But after 39 weeks, the chance of RDS is almost zero. ACOG also recommends birth at 39 plus 0 or maximum 30 plus 6. So they give 1 week time after the term also, full term also, but it is better to go and deliver before 40 weeks, according to me. SMFM, that is the Society for Fetal Maternal Medicine, has opined that labor should be allowed to occur spontaneously at term with mild idiopathic polyhydramnios. Yes, if it is mild, you can, it's like, it can be treated like a normal pregnancy, but if it is severe, better to have a controlled delivery. Severe polyhydramnios offer induction, offer, that's the beautiful word that always is used, induction at 37 completed weeks to minimize the risk of umbilical cord prolapse. If there's a spontaneous rupture and there's a mobile head, gush of fluid itself can give rise to cord prolapse and or abruption in the event of spontaneous PPROM. PROM means not necessarily always preterm PROM, even PROM, term PROM also can give us this problem. Offer again earlier delivery on a case-by-case basis to patients between 34 plus and 37 plus weeks whose symptoms are intolerable and who have not responded to amnioreduction procedure, which I have already explained. Labor management. Spontaneous rupture of membranes can cause sudden severe uterine decompression with risk of cord prolapse and or abruption. That's why controlled ARM is always better. Prophylactic gradual abdominal or transthoracic amnioreduction with a needle when the head is engaged may prevent these complications. Sometimes, even when the head is about to engage, some people believe in doing using a LP needle and put 2 fingers there and release the amniotic fluid slowly between the fingers so that the head comes down properly without allowing the cord to come down. But you have to do an ultrasound before. If the cord is somewhere near there, don't attempt all these things. Let the head get engaged, and then only we have to go for the slow release of the fluid. Check fetal position frequently to confirm maintenance of cephalic presentation. Sometimes even in labor, it may change because of the lot of fluid. The fetal heart is monitored continuously as these pregnancies are at increases for abnormalities that we know. There is a marked increase in the incidence of PPH related to atony in patients with polyhydramnios, which I have already explained very clearly. So, in other words, the management of polyhydramnios essentially includes management of polyhydramnios is one thing, management of cause of polyhydramnios, which may be diabetes, and that is easier to manage. But if it is a fetal cause, very difficult to manage intrauterine, it has to be managed extrauterine. So if it has to be managed extrauterine, we have to deliver at an appropriate time also. In all these things, there is a chance of complication. So we have to preempt the complication. So accordingly, we have to manage, we have to prevent the preterm labor, we have to prevent the maternal distress by appropriate amnioreduction, and we have to be aware of the complications thereof. And in the labor itself, there can be abruption, there can be cord prolapse, there can be PPH, there can be amniotic fluid embolism. So all these things have to be kept in mind. There is nothing to get worried or scared. Now you are well aware of what to do, and I'm sure you will manage the case of polyhydramnios very well in the exams, in the live, and in practice. Thank you very much. Tomorrow there is no class because there is a program of Dr. Sunita Tendulwarkar, and that program is Star Pravah Knowledge Series, and I've been invited as the chief guest there, so no class tomorrow. Thank you very much. Have a great night.